Very common disorder is when those otoconia get out of kilter and they're in amongst the endolymph fluid in the semicircular canals. So what we want to do is go ahead and test to see if those otoliths are located in either the anterior or the posterior semicircular canal. That's what we do the Dix Hallpike for. And this is a wonderful procedure, and patients really benefit from this. It sometimes can work the very first time that we try. Sometimes it takes a few times to do it, but patients are just amazed at how much better they end up being. Doesn't mean that they're not going to end up getting it again. Very many of them do. It doesn't mean that all they're going to need to have is this procedure, because a lot of these individuals have gone a while with this dizziness and vertigo. And so they really need to work on other items, such as ambulation, and we'll go through all that. Ambulation, turning the head from side to side, bringing the head up and down, progressing ambulation from there, so that they're back to where they need to be with normal head movement with operating. So what we would initially talk to them about is what brings on these symptoms. Is it when you get out of bed in the morning? Do you all of a sudden have that vertigo? Is it when you turn suddenly to one side and keep walking? Is that when the vertigo kicks in? And that just makes it very likely that that might be something you'd want to consider, that it might be be. Then the next thing you want to know is, have you noticed it to one particular side? Is it when you get out of the right side of the bed? And it doesn't happen when you get out of the left side. If it's one-sided and they can identify that side, then that would be the side that you would go ahead and test with a Dix Hallpike test. They might not know, or they might think maybe it's both sides. Then you would want to go ahead and test both sides. But if they can indicate one side, just go ahead and start with testing that side. And again, this is a biomechanical means of getting those otoconia back in place. Okay, so what you want to do to start with is have your patient lined up, long sitting on the mat. And you want them positioned so that when you bring them back quickly, their head is going to be off the edge of the table. And so you don't want them to lie down and then sit back up and lie down and sit back up, because that's going to mess up your test. So you can do one of two things. You can have a sheet underneath them and measure up to that area. That's one little way that you can cheat. Or you can go ahead and measure using a tape measurer straight up to figure out where he needs to be as far as this length here to make sure that his head is going to come off the edge. Okay? All right. You need to tell your patient what you're going to do, because we're going to bring them back very quickly, and you need to tell them what you're going to do. The first thing, if you suspect that it's on the right side, the first thing you want to do is have them turn their head. What a good patient. Automatically. Turn your head to a 45-degree angle in the direction that you think the problem is in. And then you're going to tell your patient that you're going to bring them back very quickly, but that you are there for their support and they're not going to hurt themselves, but you have to bring them back very quickly in order to do the test accurately. So I'm going to bring you back very quickly, flat down on the mat, and then bring your head down a little bit lower than the level of the mat. Are you okay with that? Mm-hmm. Okay. If you want to, I'm going to have you right here. If you want to, you can hold on to my arm. If that would make you feel more secure, it's entirely up to you. I'm going to support your head. Okay, you ready? Mm-hmm. 1, 2, 3. Okay, so I'm down here now, and I'm looking for nystagmus. Okay, and would the slow beat be up, or would it be down?
Should be up.
Wait,
Away from the side.
Oh.
So to the up. No.
wait, up or down? I think it
Would
would
the
be
slow
down.
beat be to the right or to the left?
Oh,
Is his
to the
slow
If
left.
beat?
the issue is to the right.
It would be
It's
down.
to the right, yeah.
So then
Slow
it'll be
beat
down.
would be
So
to the
down.
right. Okay.
To the
So I'm looking for nystagmus. I am asking about nausea and vomiting. I'm asking if he feels dizzy
You need a trash
or if
can.
he's experiencing vertigo. It's good to have a trash can close by. I am going to hold this position for 1 to 2 minutes. 2 minutes would be better. Okay. I'm still looking for nystagmus, asking about symptoms. If the test is positive, that is the end of the Dix Hallpike test. Okay, and then we would go, yes,
What angle is his head at this point off of the edge of the plant? I mean,
30 degrees
30 degrees.
into extension. 45 degrees into cervical rotation.
Now, is this ever an issue with what was it when we did for was it vertebral artery test? Is that what it was prior to doing
That was traction.
yeah, is that could that cause an issue with this?
No.
No. Okay.
No.
And the
No.
test is positive if you see nystagmus?
The test is positive if you see nystagmus. It can be positive without nystagmus. It can be positive if there's vertigo. It can be positive if he just feels real dizzy or nauseated. So any kind of positive reaction would lead you to believe that that's what the problem is.
Okay.
Okay, after 2 minutes or so, what you want to do is, if it's positive, you're going to go on with the treatment. So you're going to do the canalith repositioning, which is the Epley maneuver. And you move him from 45 degrees on the right to 45 degrees on the left.
Real quick like that.
Very quick like
That's if
that.
it's positive, now we're going into Epley.
Mhm, you're going into
Epley
Epley.
to fix it.
Mhm.
So the test is over. Now we're working on treatment.
Okay. Same thing, you ask about any kind of, you look for nystagmus, you ask about any kind of nausea or if he feels like he's going to get sick. You ask if he's dizzy, if he's experiencing vertigo. Okay, you wait a couple of minutes, and then what you have him do is come over onto his left side so that his head is facing down, because you're going to keep that 45-degree angle. You have to get down here so you can see those eyes and see if there's any nystagmus. Okay, ask him about any nausea or vomiting. Okay, and then you are going to go ahead and say, okay, Trent, we're going to go ahead and sit up. Okay, and bring his head over to. Okay, now would you go off and leave him and write a note? Not a good idea. Okay. All right, how do you feel now? Okay. Cured.
Yeah, absolutely.
Cured. Okay. So that is the Epley following the Dix-Hall pike. So the Dix-Hall pike is just bringing him back to the side that is impacted, and you get the positive result. That's the Dix-Hall pike. And then you just continue on with that in order to reposition those canalith.
How would you only do it once? The Epley.
You would do the Dix-Hall pike once to test it.
And then if it's
now,
positive.
if he was negative and you were still pretty sure that this is the problem, then you can bring him back up to sitting position and test him on the left side.
Okay.
Okay. So if he was negative on the right side and the left side, but everything that he was telling you about his symptoms really sounded like it was BPPV, what would you do next?
Try that
Roll.
Roll test.
Roll
Roll test, and that's horizontal canal, but that's only going to be 10% of your patients. So you would definitely want to do the Dix-Hall pike first, because chances are it's going to be in either the anterior or the posterior, most probably the posterior. Okay?
And how late are you here today?
As late as I need to be.
I'm seriously thinking about bringing her back, if not today, tomorrow. And just bringing her home with me and bringing her here, if you don't mind.
That's fine.
Okay.
Now I'm flying on a jet plane tomorrow.
Oh, you're going
After
to
class.
Florida?
No, I'm going up to cook my daughter Thanksgiving
Oh,
dinner.
yay, that's right, I forgot.
So, but I'll be here
Because
until about
Thanksgiving's
12:31.
all about family.
It's all about family. That's what she said.
Okay, so seriously, how long do you think you might be here today?
As long as I need to be.
Okay, I'll give you a
Yeah, we
check.
need to do check-offs, too. We need to
Yeah.
do check-offs.
What's that?
We need to do check-offs after class today anyway.
Oh, that's fine.
Yeah.
Sure, that's
Thank
fine.
you all.
Thank you.
Okay.
All right, see you.
Real nervous working in front of the boss lady. Okay, so any questions about that?
Now you know how we feel.
Lab practicals?
That's a practical.
You know how you
You
just
just felt a little
this now?
breathless.
You know how you felt this now? Think about us next Thursday.
Yep.
Just all kind of hot.
Yeah. Get all hot and sweaty.
So how do you do the roll test again?
Okay, the roll test, go ahead. The roll test is his head wouldn't necessarily need to be off the edge, but you're gonna support it anyway. You're going to have him at a 90-degree angle. Again, if you think it is on the right side where the problem is, you are going to whip that head over to the right side very quickly. Okay? So I'm thinking that this is it, so I'm gonna be moving your head very quickly. Are you okay with that?
Good to
Okay.
go.
Ready?
You think the bad side is the right side, so you move to that side?
So you go to that side.
Whip head to a fixed side.
Okay. Again, you wait the couple of minutes. You look for those same signs and symptoms. And if you see those signs and symptoms and it is the right side, what you want to do is bring his head slowly up to neutral. So slowly up to neutral. Again, you're looking for signs and symptoms. You wait another couple of minutes, and then you continue on with the treatment. So what you're going to do next is that head's going to go over to the left.
Smile chair.
So if it's positive on the right, you bring him back to neutral, and then to begin treatment, you would turn him to the left.
Exactly.
And
Okay.
then you do
So you turn him to the left, and then what's next? Does anybody remember?
No, all the way
Going
over.
into F1.
All the way over.
Oh yeah.
Okay, all the way over onto his belly. So, but he keeps his head in this position.
So
It's
is
hard to
this
keep
still, so the roll test is what we just did. It was positive for the right side. So what is this that we're doing?
It rolled.
Still rolling.
This is the treatment for horizontal BPPV.
What's the
So
name?
it would be called canalith repositioning also.
Okay,
Canalith repositioning.
okay.
Usually they refer to which follows the Dix-Hall pike as the Upley maneuver. So you're doing the same thing, it's just a different way you have to do it for horizontal just because of the direction that the semicircular canal goes in. Okay, so go ahead and get on your belly.
Keep your chin touching your
And
shoulder.
This is challenging because you need to keep him into flexion at the neck by about 30 degrees and have the head turned. Again, you're looking for signs and symptoms, nystagmus, asking about nausea and vomiting, asking about vertigo. You wait a couple of minutes and then you have him come up kind of into a quadruped position. You want to be there just in case he's dizzy and starts to fling off the mat or anything. Okay, and go ahead and sit on the side.
So
How long in each position?
Yeah, thank you.
Sorry.
When you think about something that's actually a little bit thicker, the endolymph material is thicker than water. And so what you want to do is you want to move those little rocks back to where they belong. So each position that you're putting that patient in makes them shift a little bit more until they end up hopefully going back into where they're supposed to be. So if you do this whip, 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 they're going to stay right where they are, right?
Yeah.
Think about the mechanics of all of that. So you want to have a long enough period of time where those things are actually going to do some movement. So on a lot of the stuff that you see on YouTube, they're just turning this patient. It should really be between a minute and 2 minutes, and the longer the better.
Okay.
2 minutes is really better than a minute. Okay, so those are those two things. You guys pretty clear on those? Okay. It's amazing how quickly it comes back. You think, gosh, I don't even remember anything about that. But then when you go through it real quick, it's, oh yeah.
Yeah.
It's amazing how quickly it leaves too.
So what else?
Okay, so what about the head thrust test? What are we testing when we're testing the head?
VOR?
No,
Never mind. That's what happened.
the head shaking. We're looking
The
for
head
the
shaking, gotcha.
So what are we testing when we do the head thrust?
The VOR?
VOR. We're testing the VOR, so what are we looking for when we're testing the VOR when we do the head thrust test?
A saccade?
Yes. And so with the head thrust test, we're forward at that 30 degrees. Again, you always want that horizontal canal to be parallel with the floor, and that's why you have the 30-degree angle of flexion. Forward 30 degrees. They focus their eyes on your nose or some type of a stable object, and then bringing their head at different amplitudes and different sides unpredictably all over the place. But they're looking at one thing like your nose the whole time. So if you see a little catch where they have to do a little catch up with their eyes, that would be a positive test for a saccade. Now, do you remember what you can do in terms of treatment?
The pencil test.
Yeah.
The gaze 1 and gaze 2 stability test.
Yes.
Yeah. So you can do that for treatment, and it just seems like a nothing type of thing, but it really does work for these patients.
So it helps them to adjust, and that saccade kind of fades.
It helps the saccade to go away eventually.
Uh-huh.
So if you're just moving that card and they're following and you see that saccade, what you'd want to do is slow it down.
Mm-hmm.
Okay? And then you can speed up as when they get better with that. And then you can change that and make it a little bit more difficult. You can put a busy background on the back, which can kind of make them feel nauseated at first, but that would be a way you could advance it. You could get them on a foam pad. You could get them, just move them from the floor to carpet to start with if you wanted to. So you could narrow their base of support. So anything like that you could do to increase the difficulty, and then they're going to get better and better, and pretty soon their VOR is just what it's supposed to be. So what you're doing here is you're trying to make sure that the head and the eyes are working in sync with each other. So you're turning your head to one side, and your eyes should be moving in the other direction. If you're focusing on something, your eyes should move in the other direction at the same speed that your head is moving. And if those two are out of sync and you have problems with your VOR, that's just going to make you feel awful.
In a clinic, we had a patient where we were doing similar things, where he would walk and then shake his head and focus on something.
Mhm.
But we did diagonals as well as just.
That's great.
That's okay.
That would be advancing the patient, yeah.
Okay.
That's great.
All right.
That's great, because typically if somebody has BPPV, or if they have problems with their VOR, or if they have a unilateral vestibular problem, anything like that, if they've had it for a while, this is how they're going to be moving. They don't want to feel dizzy. So they're going to be walking around like this. They're going to turn their whole body instead of turning their head. And she just mentioned with her mom that she had been told by the doctor, don't move your head suddenly. So what's her mom doing? Keeping that rigid head. So you're going to have tight neck movements, and, you know, so you need to get to the point where that person at first is just walking in a straight line. Okay, maybe turning slowly or with making a wide turn, and then eventually you want to maybe have them look to the left, and then incorporate looking to the left and the right, then up and down, and then, you know, doing some reaching activities. So you just keep increasing the difficulty of the tasks until all is what it should be. So with BPPV, hopefully you've corrected the problem, or they're working on the Brandt-Daroff at home. But with the VOR and that kind of thing, you're actually in for a unilateral problem. You're actually working on trying to make that problem better in clinic, and also make them more functional. So this is going to help with the balance. This is going to help with normalizing their gait and their head movements. And something that I left out completely when the associate dean was here and I was nervous. What is the first thing that you need to do?
Neck pathology.
Neck pathology, exactly. You need to make sure that there's nothing wrong with that neck, that they don't have any kind of neck pathology. You want to take it quickly through the range of motion to make sure that you kind of know what the range of motion is. So with the Dix Hall pike, 45 degrees in each direction. With the roll test, they say 90 degrees, but you know, you want to maximize how much you're turning their head in each direction. So you definitely need to know how much range they have in cervical rotation.
Can we go over the Brandt-Daroff and the other one that we learned?
With Brandt-Daroff is an exercise program that you can teach them to do at home. So So you could maybe have them come in the clinic and you're still continuing to do the epilepsy, and but that's kind of hard to do all by yourself at home. So they would do the Brent Daroff to follow through at home. It'd be like their home exercise program. And with the Brent Daroff, you want to make sure that they're sitting securely on the bed, and if they're unsafe because of their vertigo, then you would want to have somebody with them. Okay, and what they need to do with the Brent Daroff is to turn their head to one side and then go down. And then they hold that, and then they come back up to neutral, turn their head to the other side,
So they're always looking up with this one.
turn their head to the other side, and go down,
Call this the limp.
and then come back up.
Do they hold that for about a minute? Either
Same thing, same thing.
And what was
Doesn't matter what side they start with at all. It doesn't matter. That doesn't make any difference with the Brent Daroff.
And this is for BPPV treatment
Yes.
at home.
So the quick movement is supposed to, I guess, like initiate the fluid.
No,
For-
you're moving those
for the
rocks. You're
moving?
moving those crystals.
So it starts. That's why it's so
That
quick
That starts
to
it.
move it. Okay.
And they say that this will actually work with a lot of patients even without doing the Dix-Hall Pike and the epilepsy and all of that, but it would usually take a longer length of time. And so to do the Brent Daroff, they want to do them like about 3 times a day, about 5 times each time. So, you're spending half your day doing this. But it can be a good home program to go along with all of this.
And wasn't there another maneuver that we did?
There's the Samant,
Yeah.
Yeah.
and the Samant is really just for those, they had those theories and they kind of limited those theories about where there is cupola or canalistasis. Glad I didn't have to say that for CTFD. It's bad enough saying it for my students. But now they've consolidated that into one. So they very rarely do the Samant anymore, but sometimes a patient is just real leery of being flipped backwards, and so they seem to be able to tolerate this better. I don't know, doing a 180 and being slammed into a mat doesn't seem like it would be that much better, but with the canalistasis, you would turn the head to the opposite side of where the problem is, and then go down and hold that for a minute to 2 minutes. And then what you do is you go 180 all the way to the other side with your head down.
Bless you.
Oh, so your head is not
stop-
turning.
No stopping in between. It's 180.
Mm-hmm.
And then you come down, and again, it's like 1 to 2 minutes. And then you just come back and sit with your head still turned for a little while, and then just bring your head back to neutral.
So, Eileen, for patients who suffer from this, is it not a good idea to maybe have them sleep with their head to one side
To the
to the
opposite
opposite of the
side?
affected?
I've never seen anything along that. Hi.
I'm gonna go get her. She
Okay.
lives in Hickory, so it's an hour and a half there and back, but I'll
Okay.
be back.
All right.
Thank you.
Uh-huh.
Does that seem like it would? The pressure mounts.
An hour and a half to get there.
For real?
Yeah.
Yeah,
Hickory's
Hickory's
far.
It's what
far.
more-
Yeah.
If it works.
Yeah.
For real, yeah.
Yeah.
The only reason,
Yeah.
the only reason you would do the Samant over Brent Daroff is just like whether they tolerate it better.
They're comfortable.
And the Samant wouldn't be instead of Brent Daroff. The Samant would be instead of the Dix-Hall Pike.
Oh.
Oh, okay.
Oh, okay.
So the Samant is actually thought of as a testing procedure.
Okay.
And with the Samant, the clinician helps the force
clinician
of
is
the
there
movement.
to do the flip to the other side. This isn't something you'd be doing at home.
Right.
Brent Daroff is what you carry through with at home. So the Samant would just be a replacement, a different type of test than the Dix-Hall Pike if the patient just didn't want to be flipped over backwards.
Okay.
So the idea of them sleeping like that doesn't seem like it would be that beneficial.
It's probably not. I mean, gravity is
Maybe
probably.
if you go to bed and you just go and just stay like that.
Gravity probably isn't strong enough to do
Like
anything.
that, though, is that then they're in that same position for a long period of time.
Right.
So with all of this, you're mechanically moving those crystals. Each time you move, they're going a little bit further. So, you know, there's those pictures in the book and it's kind of hard to follow, but if all of those little rocks are there and you're moving in one direction, you know, then they're moving this way, and then you move in the next direction, they're moving a little bit further, so they end up back where they need to be. Where if you're sleeping and you go over on one side, you know, they'll probably shift, but then they
In that
will
one position.
just kind of stay there in that one position. So I don't imagine it would hurt, but unless they're doing the epley in their dreams.
Yeah. Set the alarm clock and just have them rotate that way. If they want to get better at
If
it.
they do treatment though, and then, I mean, that's a good point. If they do the treatment though, and then they go to sleep that night, will their rocks in their head not get back? And then
Well, and in the
Rocks
book
in
they
their
say
head.
go ahead and stick
Their
a
head
cervical
rocks.
collar on, but then when you
Rocks in their
read articles and such, it says, you know, don't go with the cervical collar.
So you can sleep
Put your
upright.
head in one position, that type
Sure.
of thing.
Yeah.
But an awful lot of times it'll work the first time, or the first 2 or 3 times.
Like at a
Yeah,
desk.
but for these patients who feel like they're debilitated, it seems like that's not a, that as opposed to just sleeping upright may not be a bad idea. Just an
I think it's something to think about. I'm gonna think about it myself.
I mean, if you're working towards progressing that way, and then you lay down, right? You're kind of doing away with that work that you did earlier that day. So until you get completely where you need to be, sleeping upright doesn't seem like a bad idea.
Yeah, you're right.